Physiotherapy assessment of foot pain involves a systemic approach to determine the underlying cause and to develop an appropriate treatment plan. Whether you are a physiotherapist, a student, or someone dealing with foot pain, this video is for you. Foot pain is classified on the basis of anatomical division: hindfoot or heel pain, midfoot pain, and forefoot pain. In this video, we will focus on hindfoot pain. First things first, let's talk about the patient history. This is where we gather essential information. Ask about any chronic medical condition like diabetes or arthritis. Ask if pain is typically worse in the morning, improves with exercise at first, and is aggravated by standing later. It could be plantar fasciitis. Ask if he has performed any of the following: jumping from a height onto the heel or on hard surface with inadequate heel support. It could be fat pad contusion. Sole of shoes can highlight asymmetrical wear, which may indicate biomechanical problems. Ask if he has gone through any surgery. It may lead to long-term changes in foot mechanics and contribute to current pain. Next, we observe and palpate. We will look at the patient's gait, posture, and inspect the foot for any swelling, bruising, or deformities. Two of the most common causes of heel pain are plantar fasciitis and fat pad contusion. Plantar fasciitis is an overuse condition of the plantar fascia at its attachment to the calcaneus. The plantar fascia provides static support for the longitudinal arch and dynamic shock absorption. Causes include pes planus, pes cavus, excessive pronation or lack of resupination in late stance. Activities like running and dancing, which require maximal plantar flexion of the ankle and simultaneous dorsiflexion of the metatarsophalangeal joints. Increased BMI, tightness in the proximal myofascial structures, especially the calf, hamstring, and gluteal regions. It can occur in athletes as well as non-athletes. Fat pad contusion occurs when there is an injury to the fat pad, an elastic fibrous tissue that cushions and protects bones and joints from impact, mainly calcaneus at heel strike. It occurs acutely after a fall onto the heel from a height, or chronically because of excessive heel strike with poor heel cushioning or repetitive stops or starts. Palpate two major points of foot. If pain occurs at medial aspect of the heel, it's probably plantar fasciitis. Acute tenderness along the medial tuberosity of the calcaneus is palpated. Gait pattern reveals excessive supination or pronation. If pain is felt laterally in the heel, it's fat pad contusion. Tenderness in the posterior lateral heel region is palpated. Examination is done on the following basis. Range of motion is tested for ankle, subtalar, and metatarsal joint. Clinical tests are performed. It includes Taylor tilt test, single leg squat test, and windlass test. Taylor tilt test helps differentiate between the cause. Pain confirms lateral ankle sprain. Single leg squat test is used to assess motor control. It may reveal midfoot pronation, internal rotation of tibia, and internal rotation and abduction of the hip. Windlass test is the standard test to confirm plantar fasciitis. Dorsiflexion of the big toe causes increased pain at the plantar fascia insertion. Manual muscle testing shows weakness in the tibialis posterior, calf, and hip abductor muscles. Imaging studies like X-rays, MRI, and ultrasound is also needed to confirm the diagnosis. X-ray shows presence of calcaneal spur or stress fracture. MRI shows thickening at the attachment of the plantar fascia to the calcaneus and edema in the adjacent bone. MRI often demonstrate edematous changes in the fat pad. For plantar fasciitis, ultrasound is the gold standard diagnostic test.